Good morning, everybody, and welcome members of. Something funny happening there. So we'll start again. Good morning, everybody. Welcome to Barnsley CCG Governing Body meeting in public. Welcome to governing body members and the Barnsley public. We'll start with housekeeping. We're all in different environments, so you should all know how to keep yourselves safe, which is our priority. Before we move into the agenda, we have some sad news. One of our stalwarts of primary care and CCG supporters, Mike Austin, which many of you will know, died prematurely at the age of 56 from a massive stroke last week. He was a very popular supporter of primary care and a friend of primary care and the CCG, well respected by the membership council, the practice managers group, and all of our staff who knew him. He worked for a long time as a practice manager, sometime in Rotherham, but in Barnsley with Dr. Niogi in Thurnscoe and Great Houghton, which is one of the areas among our most deprived. He was a great champion for the people of Thurnscoe and Great Houghton. So in respect of Mike, I'm going to ask you to switch off your cameras and microphones for 1 minute, and then we'll rejoin the meeting. Thank you. I think we're all back now. So that was a minute's silence in respect and value of our colleague Mike Austin, who's passed away. So let's move on with the rest of the agenda then. Apologies, Kay, do we have any?
We do. We have apologies from Dr. John Harburn and James Sivakumar.
Thank you. And are we quorate?
We are quorate, yes.
Thank you. And I understand we have a video for the patient's story. Kirsty.
Yeah, I think we've got Jeremy who's going to do an introduction for us.
Jeremy.
Yep, so I've got a few words just to give us a bit of the context. Item, Project Stride is agenda item 13 as well, so this is kind of the prelude to that. So the patient story this month relates to that item on the agenda. It's about a digital service created in partnership with clinicians, industry partners and residents to promote healthy aging experiences, which, as you know, is a major cause of people becoming ill in Barnsley, and that we'd like to prevent as early as possible. So the story today comes from two local residents, Tony and Margaret. They took part in a small service evaluation, which we call the Alpha Pilot, last year. It describes their own situations, including concerns about health, how they hope the Stride service could help them, and it was recorded before the successful trial then began. So the frail population in Barnsley is growing at a greater rate than the overall population is growing or ageing. Frailty is progressive, it impacts adversely on life experience, and if unmanaged, it can cause the sufferer to become very sick very quickly. We know that the COVID pandemic has increased the burden of frailty on our population because of deconditioning associated with high levels of inactivity and isolation. So Stride combines some nutritional support, coaching and education to help people take control of their health, increase physical activity, social connections and well-being that can delay or even reverse frailty. So we're hoping that sharing these stories today will stimulate discussion when we get to the item on the agenda, and that ultimately governing body will want to support continued work with our partners across Barnsley and our industry partners as well to explore this opportunity in more detail in the beta pilot that is set out in more detail in the item 13 agenda item. Kirsty, over to you.
Thanks, Jeremy.
Can't hear Kirsty. Can't hear Kirsty. Can everybody hear this? I can't hear it.
No, there's no sound.
No sound.
Can you not hear it? Nobody.
No.
No.
No,
there's
Kirsty,
no
yeah.
sound.
Yeah.
Right, let's come back out and let's go back in again. Right, Nick, when I play, if you can hear it, give me a thumbs up. If not, give me a thumbs down. Thank
Okay.
you. Okay, bear with me, colleagues, while we see if we can do an alternative version. Now, I'm going to suggest, if it's
Yeah.
okay with you, Nick, that we pick this back up at the end, and we'll see if we can work out the gremlins in the system.
Yeah, and I think we've got the paper in item 13.
We have, yeah.
Space for discussion then. I think it's fairly comprehensive.
Okay, apologies for that, colleagues, but we'll see if we get the gremlins sorted.
Yeah, okay, happens.
Thank you.
Okay, one other thing that would be nice is we've got a lot of cameras that have stayed switched off, and I think as it's a public meeting, it would be good if some people would allow their faces to be seen. So I think put some of these cameras, switch the camera off, so we can see some of you. I'm sure the public, if they are viewing this, are not viewing it for a set of discs. Thank you.
Nick, sometimes on your screen it doesn't show everybody that's got their camera on. So they might, if you've only got 9 people showing, it's just the way that the screen's set up. So other people may have their camera on, but until they speak or move, they'll not pop up.
Okay, that may be what's happening then. I can see 3 people. So apart from Kirsty, Jeremy and Jamie and myself, is anybody else, can anybody else actually see themselves?
I've got 9
Yeah.
on screen.
Yeah, I've got 9. Yep.
9 for me.
I've changed mine to large gallery and I can see 4.
So how do I get,
16.
okay, how do I get to see 9 then?
If you click on the 3 buttons at the top,
Yeah,
as it comes down, if you pick either gallery or large gallery.
I've
Large
got
gallery.
gallery ticked.
Yeah,
Right,
large
you should-
gallery is that you'll see more people then.
That's better. Thank you, Roxana. So I'm sure that's more reassuring to me and to the people of Barnsley. Good, I can see lots of people now. Okay, so patient story will pick up stride in item 13. Item 5, declarations of interest relevant to the agenda. Then as the report, are there any new to share or update? No? Okay, can we then move on, Kirsty, to item 6, patient and public involvement activity report, please?
Okay, thank you, Chair. So this month we've got 4 items on, a couple of items that the CCG's led on and a couple of items that we share. So each meeting we try and bring a mix of things that we've been working on, so core CCG business and then things from our wider partnership that will help inform some of our future work. So the main one that we're feeding back this month is the feedback from the all age mental health strategy. So you'll remember that we brought this back. I think it's probably been to the past 2 or 3 meetings, and we've got the full feedback now. So that feedback has been fed into the Mental Health Partnership Board. Some of those suggestions, reflections, people's views have influenced the final strategy, and the final strategy, I understand, is sort of working its way through the system and going to Health and Wellbeing Board for sort of final sign off. But I wanted to include the feedback here because I think it's really important. So one of the things that we always try and do, you know, people might be talking to us about the mental health strategy or mental health services or their experience of mental health and wellbeing, but there will be a read across to other areas of work that we're working on. So I think it's really important to make sure that we look at it as part of that bigger picture. So I don't propose to go through all the findings, but just encourage colleagues to really look at that and understand some of the people's feedback and how it might apply to their areas of work. And then finally on that one, I just wanted to say, you know, a really big thank you to everybody that did feedback. It's been quite a long process that we've gone through on purpose. So we wanted people to be involved at the beginning rather than just going out with a strategy and saying, tell us what you think of X, Y, and Z. So people have collaborated with it, particularly the Barnsley Mental Health Forum, who've been part of that work and really central to sharing their views and actually gaining some of the views for us. So that's the mental health and wellbeing strategy. The other couple of items in there you'll note, and one of the ones I just wanted to flag was our colleagues at Swift, so our community and mental health services provider in Barnsley. They're looking at shaping their services in the future. So they've got quite a broad ask, and they're asking people, you know, help us shape our services. What sort of things do you want to see in the future? So a very broad question, and it sort of sits alongside all the other development work that we'll be doing in Barnsley. So they're going out and asking people about that at the moment, and we'll bring those results and feedback back through this forum. And then they're the main ones that I just wanted to flag for colleagues this time. Thank you, Chair.
Thanks, Kirsty. Any questions for Kirsty? Okay, so thanks for that report, Kirsty. We move on to 7 then. As far as I understand, we haven't received any questions from the public for this meeting.
That's correct, yeah, we haven't.
Okay. Can we then move on to item 8, which are minutes of the meeting of the 20th of January. They're here for approval or any clarification that people may wish to seek. Taking them as read, are people happy with the minutes? Yeah, okay, so we can approve those minutes. That's good, thank you. And we move then on to item 9, the matters arising report. Anything anybody wishes to pick up there? The cancer assurance report, some of that is on later. It looks fairly complete to me. Is there anything there that's outstanding that we need to pick up? No? Okay, that's good. Thank you. Can we then move on to Chief Officer's report? Please, Chris.
Thanks, Chair. So just to bring governing body members up to date, that apart from obviously keeping our services running as we'd wish, the 2 big things affecting our organisation at the moment is, the first one is trying to, as we come out of the Omicron wave of COVID, we're trying to come up with a plan to tackle the backlog and come up with a plan for financial year 22-23. So that's something we'll report back on future governing body meetings. But just so the other thing is trying to manage the transition from clinical commissioning groups to integrated care boards, which is currently scheduled for the 1st of July this year, which is subject to parliamentary approval. So the update today is really on the second of those updates, is to talk about progress in the transition to an integrated care board for South Yorkshire on the 1st of July. So some appointments have been made to the we call them designates because the accountability will still be with CCGs until the 1st of July. But there's been some designate appointments. We know we've got Piers Butler as chair, with Gavin Boyle as chief executive. Cathy Winfield, who's will be chief nurse at the ICB. I've been appointed to the Deputy Chief Executive and Rotherham Place Director role, but just to reassure governing body members that I will be absolutely with Barnsley CCG as accountable officer until the 1st of July or whatever period the Parliament decides. Christine Joy has been appointed Chief People Officer. Dr. David Crichton, who is the clinical chair at Doncaster CCG, has been appointed Medical Director. Lee Outhwaite, who's currently Chief Financial Officer at Chesterfield Royal Hospital, has been appointed Finance Director, and Will Cleary-Gray has been appointed Executive Director of Strategy and Partnerships. The key thing for Barnsley going forward, there were 3 vacancies that are being advertised, which are place directors for Sheffield, Doncaster and Barnsley. Obviously, we'll have a lot of interest in the Barnsley appointment. The schedule for that appointment is the last week in April will be the selection process. So we would hope an announcement in May for the successful candidate. And then I would expect myself and the rest of the exec team and governing body members to work with that person when appointed to ensure a smooth transition to the future. So I'll just pause there, Chair, see if there's any questions.
Can't see any questions. So I suppose, Chris, congratulations on your appointment and to your colleagues. And we look forward to, as you say, a smooth transition and appointment of a place director for Barnsley.
Thank you.
Anything else you want to say, Chris?
No, I think probably just for next time, for when we next meet, we'll be updating the governing body on, particularly on the financial and activity plans we've got. And just for so that the public, what we're planning on doing is we're going to try and run at 110% of normal capacity during 22-23 is the plan. So we're trying to come up with something that can deliver that, so we can start to tackle the backlogs caused by the pandemic. So that's something we'll bring next time.
Okay. Thank you. Thanks, Chris. So we'll move on then. Item 19, COVID-19 response. Jamie?
Yep, thank you. So taking that governing body members have had an opportunity to read the paper, there's a couple of key points I wanted to bring out from this. So the first, which we will have all seen, but came from following the previous meeting, was the government publication of the Living with COVID plan. So people will be aware from 24th of February, most of the restrictions were removed, including legal requirement to self-isolate for those people testing positive and for close contacts, even who are not vaccinated. So the legal requirement changed. The advice was still to do so. From the 1st of April, free universal testing will also end, and testing instead will be targeted at the most vulnerable. So quite a big change there in terms of our response to COVID and how we protect. NHS England published a letter which was an update on that, particularly for the healthcare sector, and confirmed a number of things. So firstly, that whilst the restrictions have changed out there in the public, health and care staff who have tested positive for COVID-19, whether feeling ill or not, should not attend work until they've had 2 tests. So no change there. The obvious difference would be that people may not be testing in the way that they were previously. There's an expectation of some further guidance around some of the specific details around testing protocols and things. At the moment, what we have had is confirmation that infection prevention and control and testing arrangements in primary care, acute and other healthcare settings remains the same. So there's still a requirement around masks. People going in for hospital surgery or treatment are still required to test beforehand. All that will remain unless we are told something different. and there's a supply of the universal test out until at least the 31st of March to support that. After that point, we'll get some further detail as to how health and care staff can access the tests. So I think they're the key things around that document related to health. I think I just wanted to pick out the JCVI statement, which I think is leading to our sort of next phase of planning for vaccination. So Joint Committee on Vaccination and Immunisation recognises that there remains considerable uncertainty with regards to the likelihood, timing and severity of any future wave of coronavirus 19 in the UK. There may be a transition period of a few years before a stable pattern such as a regular seasonal wave of infection is established. And then it recognises advances in the vaccines and the benefits there. So in the context of that advice, we've received planning guidance around the vaccination, and there are three priorities that are identified. So the first being continued access to the COVID-19 vaccination. So that includes a vaccination offer to all children aged 5 to 11. That will commence in April, so that's new. This is not those that are at risk. This is all 5 to 11-year-olds who will be able to access the vaccine. A vaccination of a spring dose at around 6 months for those aged 75 years and over, residents in care homes for older people and individuals 12 and over who are immunosuppressed. That will be at a 6-month period from the sort of previous vaccine. So we expect that to start really in mid-April, because we didn't see boosters starting until mid-September. Continued vaccination offer to those who have recently become eligible, so that evergreen offer for anybody that's in a cohort that hasn't yet been vaccinated. Continued community engagement to improve confidence, and also appropriate access to overseas vaccine records, so for people who have been vaccinated overseas to get their NHS records updated. So that's the first. And then the other key element is a delivery of an autumn COVID-19 vaccination campaign. So that is only if advised by JCVI. So the planning is there, but as yet there's not a recommendation that it happens. We've been advised to plan for 2 scenarios. The first being cohorts 1 to 6 being vaccinated, which is everybody over 65, and those who are deemed to be clinically vulnerable or at risk, and health and care staff. The second, which would be larger, would be a full another booster campaign for everybody in the original cohorts 1 to 9, which is everybody over 50 plus clinically vulnerable health and care staff and done. So we're working through that with the BCN and Barnsley Healthcare Federation to make sure that we've got an offer running through this year that can step up in terms of capacity through the sites we've got. We're asked to minimise any impact where possible on any core activity in primary care. So we're working on that. And then the third element of that plan is around detailed contingency plans to rapidly increase capacity. So we are being asked to be able to, within 2 weeks, at any point during this next year, be ready to step up capacity. So from a Barnsley perspective, what we've done around that is made sure that we've got access still to the 3 sites where they're not all being used at the moment, but we've kept access to them so that they can step up. We're trying to make sure that the staff who have been involved in vaccination, administration and all the rest of it are kept engaged and working at times so that their training's up to date and other things, so that we can step up if we are required to deliver another response, as we were just before Christmas when the Omicron variant came out. There's a number of appendices with the detail behind it, but that's what I wanted to bring out, really. I'll take any questions around any of that in terms of the plan or response.
Thanks, Jamie. Chris?
Jamie, good morning.
Morning.
We all know that COVID has not gone away, and our hospitals certainly have ongoing concerns in relation to that virus. So, bearing in mind that we're in public, do you have today's hospital C19 inpatient total? I'm particularly interested in maybe the movement from last week to this week. Has it gone up? Has it come down?
I've not got the exact number in front of me, and I'm looking at my screen because there's so many people, and I don't know whether Jeremy's got sight of it, because we do get it coming through, Chris, but I've not seen it on here. It had been relatively stable, it had been reducing, but we did see a bit of an increase in the numbers. I think it had gone back to 60.
61, yeah.
And it had been down quite a bit lower than that. The other part of that is that what we're not seeing is a increase in terms of those who are seriously ill because of COVID, or who are on critical care and with ventilation. So we're not seeing that. The majority of people who are in hospital as inpatients with COVID are in for other reasons and then test positive for COVID. So that's the current position. So we're not seeing a big increase in numbers of people being admitted because of illness related to COVID.
Chris Edwards. Chris, did you want to come in?
Yeah, thanks. Yeah, so Jamie, I've got a little bit more up-to-date information on that. So we are starting to see a slight upturn in the infection rates and hospitalisation rates across the country. The southwest particularly has been experiencing high hospitalisation rates. But in South Yorkshire this week, we are starting to see an upturn in the numbers. So where they had been decreasing really on a really good trend going down and getting down to quite low numbers, we are starting to see them go up again. The public health professionals, obviously it's too early for them to start to make judgments and predictions. So the public health professionals are sort of saying it's a watch and see situation. We don't know what's going to happen next, but there is something in terms of it's either levelling off or a slight upturn.
Yeah.
Thank you. Thanks, Chris. Mike?
I think we don't need to be lulled in a false sense of security, because most of the positives are people going in for other things. But it's been shown that if you have an operation, especially a major one, and you have COVID, your mortality rate is much higher than if you have it without COVID.
Mm.
So the fact that they're not ill with COVID when they go in is translated to a high mortality for whatever they go into. So it's all right people saying, well, it's just a positive test, it doesn't matter because they're not ill with it. It does have consequences for them and their hospitalisation.
Thank you, Mike. Are there any other points or questions for Jamie? I have one, Jamie.
Yep.
End of free testing, 1st of April. So
Yep.
Patients that present, this seems to be a gap in the thinking. I would seek some assurance on this, and you might be able to give it. I don't think you'll be able to give it. Free testing ends 1st of April. So patients present to primary care very frequently with symptoms that mimic or can be like mild COVID. In the absence of free testing, that's going to expose the whole of the primary care workforce to an increased risk. I'm not sure if the systems thought about how they're going to manage that, because whilst healthcare workers do protect themselves and people are meant to stay on with the precautions, there will be people attending with symptoms, or we're going to have to send them somewhere else. Now, we won't be sending them to A&E, so this is a gap in the thinking, and I just wonder if others have picked it up or made any plans.
It has been picked up in a number of places and raised back. I can't give any assurance on what's going to be there because we've not had that yet. So we've fed it up through the vaccination route. We've fed it in through a public health route as well. So through Julia and up that way, because it's within primary care, but it's other vulnerable groups. So there's nothing yet come out to clarify what is meant by targeted testing for those who are vulnerable. So does that include health and care staff? And there's nothing yet come out in terms of the guidance as to how we'll access those tests and how they'll be provided. I mean, there will obviously still be available paid for tests, but people are not going to go out buying big numbers of paid for tests if they're not feeling ill, are they? So I'll keep pushing that message, because we're getting close to the 31st. It's only 3 weeks away now, isn't it? And we need to be ready for that.
And I think as we do more face-to-face, and the public expectation is more face-to-face, it becomes a bigger risk for us than remote consultation. So thank you for taking that forward.
Yep.
Are there any other questions on the COVID paper for Jamie? No? Okay, thanks, Jamie.
Thank you.
Move on to item 12, Jeremy, integrated care at place presentation.
Thank you. So this is an update on integrated care as expressed through our partnership health and care plan. So I think a short set of slides was circulated to governing body this morning, and I'll just run you through some of that now. So this is for information at this stage, not for approval. It's a description of the process, some of the successes over the last year, and some areas where we think we want to carry on pushing further and harder into 22-23 as well. Richard, I think you've kindly agreed to do the honours of putting the slides up for me.
I have, if you just bear with me 1 second. Can you see that? Is that?
Yep.
I can. Luckily, there's no sound required. Yep. So, Richard, move us on to the second slide. Thanks.
Okay.
So we're just in the process of refreshing our health and care plan with our partnership colleagues, because Health and Care in Barnsley, governing body, be well aware of the 1 year plan we had for 21-22. And we're just in the process of refreshing that now for 22-23. And you won't be surprised to see again, just a reminder of our approach in Barnsley, how we want our partnership to work and to deliver better outcomes and better efficiency. It's underlying principles around teamwork, removing barriers, and our thriving communities. So, second slide. Thank you, Richard. We'll move on. So it is a light touch refresh. I don't need to remind colleagues about the operational challenges we've all faced over the last few months. We've had to revise the milestones associated with our 21-22 delivery plan a number of times as we've been through different phases of COVID. But nonetheless, we've made, I think, some really quite considerable progress as well. We're now in the process of just reviewing our partnership plan. And it is just important to remember this is the partnership plan. This isn't the totality of activity being undertaken across Barnsley. These are the particular priorities where we think that by working better together, we can deliver better outcomes for the people of Barnsley. We have a process we're working through at the moment, as articulated in sort of the arrow in the little boxes that are in there. It's a bit hard to read, so I'll just go through that with you. So on the left-hand side, we've got our PMO reporting, our highlight reporting in place already. So we're already reporting through progress against the plan to our integrated care partnership group. We're just undertaking a stock take of progress to date with the senior responsible officers against each of the existing priorities and mapping them against the latest NHS planning guidance for 22-23. And then we are moving through in the sort of the amber orangey section, again working with SROs and program managers to get their thoughts and feedback into what they'd like to see happen in 22-23. And into that, of course, we are playing in all the engagement activities that we've undertaken as a CCG and in our partnership over the last few months as well. And as we move towards the right-hand side of that, we will then be moving towards signing off our partnership plan at our Integrated Care Partnership Group at the end of March. And one of the key things that we've got to focus on this year, where we didn't have to focus so heavily last year, is around the implications of the plan in delivering increased efficiency and increased activity and throughput into our system as well. So that's an area where we need to introduce additional focus over the coming weeks and months. And I've got a meeting of our partnership next week where we're going to be considering the draft plan as it exists, and also thinking through how we do work together more effectively as a place to increase efficiency, flow and throughput as well. And just also really worth focusing on the fact that this is a light touch refresh of the plan, and we expect and will be required over the course of the summer to really work with our ICB colleagues across South Yorkshire, and also in our places to refresh our 5-year strategy as well. And that's where we're going to take a really fresh look at what it is we want to collectively be achieving together. So we've got a light touch refresh, mostly a carry forward of existing priorities, and then a chance to really look again and make sure we get our 5-year strategy right over the course of the summer. Next slide, please, Richard. So hopefully you can see some of this on the slides that were circulated to you as well. For each of the different priority areas or sort of transformation areas, we've had really quite some successes over the last year as well. Despite all the operational pressures that we've been under, colleagues have continued to work on service transformation and delivering improved services and outcomes. Some of those are just highlighted here for you. So for instance, under planned care, you can see better the use of the referral assessment service and advice and guidance for primary care. Hospital has been working hard on rolling out PIFU, patient initiative follow-up, for outpatients across major specialties. In mental health, and you've seen in the engagement report, we've produced an all-age mental health strategy to underpin delivery across our partnership. Through to, for instance, in digital, we're working together on implementing a shared care record, again, with our ICB colleagues, adopting the Yorkshire Humber Care Record. And there, for instance, we've just appointed a digital programme manager to see us through that process over the next few months. So quite a wide range of areas where the partnership, those frontline service colleagues across health and care have continued to engage with our transformation activities, despite the operational pressures that they've consistently been under. And I think that's worth applauding, actually. We'd like to go on further, and I think we've got a real opportunity over the spring and the summer this year to really identify a number of key priorities where we are determined to make progress before we enter what is likely to be a pressured winter period for autumn and winter next year. On to the next slide, please, Richard. So we got some carry forward from the existing plan, where we know we need to want to show more progress over the next few months. So on digital, for instance, we've got a commitment to deliver a local shared care record solution by April 23 to align with national targets, and we're putting in place detailed plans to carry that forward along with our ICB colleagues there as well. Our vaccination programme will continue, as Jamie was talking about just now. And then on the care close to home, for instance, we're looking to see how we can expand the scope of the services that sit within our neighbourhood teams. So you know the mobilisation for that has gone well, despite operational pressures. We want to move on now to think about what comes next. At governing body prior to COVID, we talked about the third phase of neighbourhood teams being mental health services, so we're keen to move ahead with that. But we're also really keen to bring into that conversation adult social care in particular, but also our PCN colleagues as well. So we are together making the best use of the additional workforce that's coming into primary care, and also making sure it aligns with the service specifications that they already need to deliver. So there's a whole range of areas where we've made progress, but we want to move together over the next year to deliver even more. And then next slide, please, Richard, last slide. So these are some of the possible priorities that are coming out of conversations at the moment. You see a whole range of them, unsurprisingly. When you look across the whole system, there's a lot of things that people want to do. One of the challenges for our partnership will be to focus down on some of these priorities and make sure that we actually are able to deliver or make substantial progress in delivering them over the course of the spring and the summer, when we expect to have additional capacity across our health and care workforce to really engage with these issues. This is not necessarily a comprehensive set of priorities coming out at this stage. It's very much a work in progress. And as I say, over the next couple of weeks with partnership colleagues, we'll start to collate all the feedback from the process that I outlined earlier and think through how that looks in terms of updating our one-year plan to refresh it. What are we holding on to? What do we want to re-emphasise? Are there any new priorities that we do want to focus on over the course of the next few months? And that will go to our Integrated Care Partnership Group for discussion and potential approval at the end of March. And I will be bringing it to governing body development session as well in order to go through it in more detail as that plan starts to take more shape. Nick, that's just a quick run through of the process and some of the successes and areas where we think there's more to do.
Okay, thank you, Jeremy. There's a question here from Chris.
Jeremy, it's not so much a question. It's more sort of setting the scene for the future in terms of, let's say, Barnsley Patient Council. Stride, this is an NHS promotion, yes? And there's an awful lot there to digest. All of the headlines you've shown us this morning look pretty good to me. But is this programme being provided by a private enterprise?
Chris, I think I'll just stop you there because I think Jeremy hasn't gone on to Stride yet. I think we're still at integrated care, item 12.
Apologies.
Accepted.
I'm ahead of the game.
You are. The question's relevant. We'll need to think about how that factors into the overall plan. Yep.
Yeah. So the bit about public engagement, I think, is really important and how that's modelled into the planning. Did you have any other point there relevant to item 12, Chris?
No.
Okay. So are there any other questions for Jeremy or any other things you want to say, Jeremy?
No, I don't think so. I think, I mean, it's always hard to get across the scope and breadth of these plans in the time we have available here and the amount of detail that sits behind many of these areas. There's always more we want to do, and I'm really keen, and I know Roxana is as well, that we use the plan as best as we can also to really think about reintroducing our QUIP planning for next year as well. And I think that is a key objective for us, and we've got to find a way of unlocking and working together across our partnership to really help us not just deliver improved services and outcomes, but really help us to understand how we can improve efficiency and throughput as well. And that's a big challenge for us moving into 22-23.
Certainly is. Okay, so if there are no further questions, thank you, Jeremy. And we'll now move on to item 13, Project Stride. And I understand Jamie McGuinness is going to help us with this and take us through it. Jamie?
Hey, thank you, Nick. So Stride is a programme to manage frailty, as both Jeremy and Chris have alluded to. It's a combined sort of public-private project. Initially, there's been an alpha study which is run within Barnsley with, I think, 12 residents who've been identified as frail. And the Stride project was looking at a combination of online support and managing, sort of trying to prevent the progression of frailty within that population. As I think Jeremy alluded to earlier, frailty is one of the major growth areas within health. It's rapidly increasing within Barnsley, higher than both the population of Barnsley and the rate of progression of age. And frailty is increasingly found to be one of the major risk factors within hospital admission and, unfortunately, death. So if we can try and help manage that, prevent its progression, then it will make obviously quite a significant leap forward towards preventing hospitalizations and improving health within the community. the initial project has been done, so that was the alpha stage, and the current request is the moving on towards the beta project, which is moving on towards an increased number of people on a trial, and also the provision of, I think, combination of energy and protein drinks to try and see if that would help reduce frailty further within that group. But Jeremy has a much better grasp of it than I do.
Yeah, unlikely, Jamie, but thank you for that. The ASCII governing body is relatively straightforward. It's worth noting, I think, that I was hoping to have a Swift clinician on, but she hasn't managed to join us just yet to answer any of the questions around sort of the alpha trial. We took this to our Care Close to Home board a couple of months ago, and it was very well received there. It's well received across the partnership, and worth noting, a governing body, that as we move into the beta pilot, we still need to do quite a lot of work to really define how that beta pilot's going to work in detail. That there is obviously considerable investment being put into this from our industry partners, who are effectively picking up 66% of the total costs of running that pilot, and also any overruns that might occur, unexpected overruns, that the risk will sit with them. The remaining 33% or so is being shared across our health and care partnership. So we will be getting matching equal contributions, we hope, if you approve this, from the CCG and from BMBC, split there between social care and public health, and from Swift as well. So it's a genuine partnership approach and has got really solid buy-in across our partnership. I think it's quite exciting, actually. There's a lot of lessons still to learn on this. The alpha pilot, if you look at some of the evaluation results, which are on page 84 of our pack, sort of take you through the highlights of that alpha. And hearing from patients, as you would have done in the earlier video, but also from the experience of clinicians involved with it, it does, I think, have real potential. The purpose of the beta pilot is to see what else we can learn, we can refine it, and critically to see whether it has any potential to scale up as an offer. You can't, our intention would never be to continue to offer this to a very limited section of the community. The purpose of this is to make it a widespread, wide-scale offer. Clearly, that can only be done if you demonstrate that the benefits are worthwhile and that the investment really into that is something that we think will deliver appropriate returns, both in terms of reducing frailty fundamentally. And I think we do need to remember we have a population in Barnsley where if we don't do preventative work, we don't undertake investigative activities, we will be seeing increased costs and increased frailty and increased comorbidities in our population continue to persist. And obviously we want to do all that we can to prevent that. We're working with ICS colleagues as well, and there's interest in the South Yorkshire level in seeing how this programme develops. Hoping that you're as interested as we are and want to see it progress. And in terms of the ask, I think, Roxanne, if I've done my sums right, the ask is, what, 54k, I think, for governing body today. Is that right? No? Tell me what it is then.
Yeah, sorry, Jeremy. I have sent you a message this morning. I tried to call you.
Sorry.
So the ask today is for up to 80,000, because there is some debate still going on in the local authority about the size of their contribution. So far, we've had confirmed that they'll contribute 27k. Swift have confirmed they will contribute 53k. So it's up to 80,000, depending on the conversation with the council at the moment around public health contributing.
Thanks, Roxana. So I'm keen to kind of move it on to the next step. We've already delayed it for all the obvious reasons around COVID. Quite keen to make sure we can get this underway and learn the lessons. And I think we've got a commitment as well to take it back to the wider partnership as well. So and see if we can spread the cost even further, even more widely across the wider partnership. Joe, you're on the line as well, and I can see now that a colleague from Swift has joined, Sarah Armour. Hi, Sarah.
Hello, thank you for inviting me along to this part of your meeting.
So Sarah's the Swift specialist dietitian, and you've been involved with the programme throughout. I don't know, Sarah, whether you want to say just a few words about what you've seen so far and your aspirations for the programme in the future.
Yeah, sure. Thank you. So we were really excited to be able to be involved in this project as a team of dietitians. So I lead the team of community dietitians in Barnsley and also work as a specialist tube feeding dietitian myself. And for me, this project is really close to my heart because a lot of the patients that we see in the community are already frail, they're underweight. And for me, something such as this project to be able to have these patients highlighted to us before they get to that point is really, really important, and so important to be able to empower people on a level that means something to them. So we've seen, in the past that sometimes patients aren't interested in what their weight is, or, are they gaining weight, losing weight? Sometimes they have no interest, but what they do want to be able to do is go to Asda Cafe on a Wednesday with the next door neighbour, or they want to be able to walk the daughter down the aisle, or all of these things that are sort of reframing those patient goals to what's important to that patient as a person. I could talk to you all day long about nutrition and hydration and why that is important. And, before we treat anyone with any medicine, and I guess I would say this, but before we treat anyone with any medicine, they've got to be nourished and hydrated, and they've got to have the fuel in their bodies to be able to move and live and grow. So I feel particularly passionate about this. So we worked on this project, which has been going on for a number of years now to get us to this point. And I feel it's a really positive thing. And again, just framing this as keeping people as well as possible for as long as possible, and having them truly take ownership of that in a way that's meaningful to them, and they're empowered to do that. I'm sorry, I feel like I'm waffling now, but it's because I'm excited about it.
No, thank you, Sarah, for that. But I think there are a few questions that I did ask of Jeremy yesterday, and the governing body members may wish to pick up some of that conversation. But first of all, because there is a fine balance, isn't there, between what people do for their own nutrition and eating and what is actually medicinal and prophylactic, and where that line is drawn, and also the cost effectiveness of that. So there are a few issues, and I think that we need to just bottom those a little bit. Jamie, can I bring you in? You've had your hand.
I had some reservations about this project when I was first involved, but I think the pilot study that's been undertaken has shown potential for the reversal of frailty, and currently we don't really have any evidence that other things have been effective. We both in Barnsley, we are trying to increase exercise, we're trying to improve people's engagement with services, but in terms of actual evidence of reducing frailty, we don't really have it. And the Alpha trial showed the potential for that to take place, but the problem is the study is too small for any real evidence to get there. And I think the better, whilst it is an expensive undertaking, actually has potential for the reversal, has potential to show real evidence for the reversal of frailty within the community. And I think that's the thing we've got to sort of ask ourselves is, are we willing to take that risk but unfortunately bear that expense?
Yeah. Okay, so I'm glad you brought that up. So, Mike.
Yeah, I mean, three things. First of all, we're told to avoid, as doctors, avoid jargon. And I think using phrases like face-to-face onboarding perhaps is not common English. The costing, is it 480,000 for 3 months for 2,000 people, which works out at £2,000 a person, or over £2,000 a person for 3 months, which seems quite high. And the third question is, I mean, knowing that there's no such thing as a free lunch, what's in it for Abbott?
Okay, so that's a very important question, Mike. So I did pick this up with Jeremy yesterday and asked if we were confident with any perceived conflicts of interest. I understand there are no conflicts of interest. However, if you remember at one time, GlaxoSmithKline, as a pharma company, had a bigger turnover than many of our Eastern European countries. So pharma companies influence subtly in many different ways. But Jeremy assures me and we'll bring, I think, Joe in a second, that there are no conflicts of interest. With regard to the offboarding, one of the things that, and I've discussed this with Jeremy, and I'm pleased to see that this has been to the senior management team and that our medical director and head of meds management have been involved, because one of the things that we as GPs have been strongly discouraged to do is to prescribe inappropriate nutritional drinks for patients, and to limit their prescribing to where there are perhaps the severe frailty, palliative care, swallowing difficulties, or where it's simply not possible for the person to ingest enough quantity of normal food, so they need a more concentrated volume. One of the things that we've struggled with in primary care is to get away from this trend of prescribing nutritional supplements to everybody that wants them. And so one of the questions is, when this project is discontinued, will that change the prescribing culture, and will we once get again into prescribing them? So the reassurance I've had on this is that part of the beta study will look at how this, what's been described as offboarding, will not take place. So at that point, I think have I got Joe Minton with me? Joe, did you want to say something?
Yeah, I wonder whether Sarah might respond to that clinical part, and then I'll come back on Mike's points around the pilot.
Okay, Sarah.
Yeah, sure. Thank you. As part of the project in its early stages, I think Abbott, I don't know who's on the call, and I don't want to talk out of turn. I'll just be honest, because that is just
I think we're in
who I am.
We're in public, so it's good to be honest.
Yeah, sure thing. I feel very strongly, because Abbott obviously, well, not obviously, but they do make a lot of the products that are used in Barnsley on FP10, so like your Ensure Plus and all of this. And I feel very strongly, and us as a team, just inherently, we really do promote the food first strategies first. We'll only go to prescribing if there is a clinical indication and with monitoring parameters in place. And I think they were keen to sort of have this project have an element of a product in there. And if you speak to anyone who's involved in the development, I kind of really did dig my heels in a little bit and said, this is not the right thing. This is not what it's for. And also, I don't want us as dietitians or Swift or whatever to be affiliated with something that just effectively looks like selling products by the back door. And so categorically no. And when they did the alpha pilot, it was very much like, oh, if there was anyone who was appropriate to be on a product, then maybe they could have this. And I was like, if there is anyone, then we as clinicians will be the people who decide if that's appropriate and what they should be on, because that might not even be a product full stop. And even if it is, it might not be an Abbott product. So I've been very clear the whole way to separate those two things. From a professional integrity perspective, it's just not the right thing. And I think going back to what I said right at the beginning, of this doesn't need to be over medicalized. This is about people as individuals eating and drinking foods that they enjoy, that's meaningful to them from a health and a social perspective. So 100%, it's not about the products. And I think, like I say, as a team, we're very, very focused on food first. And if we can meet someone's nutritional needs by food, then we will do it every time. Okay. Joe, do you want to come in, please?
Yeah, thanks, Nick. And Sarah actually responded to about what I was going to say. And that's why it's so important that we do this pilot together, and people like Sarah and Chris and others are involved, and we will be designing that onboarding, offboarding process before the pilot to give some assurances to the clinicians that we're going to get this right. Apologies for that language of onboarding, offboarding, Mike. Just to pick up on the point around the costings. So the investment in beta is not per capita cost of delivering the service. So it's about developing some of the components of it. It's about the evaluation. It's about assessing the cost benefits, the investment model. So the product you get at the end of it, hopefully, will say whether or not this can be delivered at scale, providing good outcomes for patients and value for money. And it won't be anywhere near that cost point, Mike, because we wouldn't no commissioner would commission it on that basis. So that's why we need the beta study, because the alpha, as you say, is such a small number of people, it's difficult to determine what that the outcomes and the value for money proposition. Yeah, I think that's all I'd say, unless there's other questions on that, because Sarah covered that.
Okay, so Mike, you wanted to come back in on that?
No, I think what Sarah says is very reassuring. I mean, we saw this thing with stomas a few years ago, where certain companies were willing to pour a lot of money into hospitals as long as they just use one product. I think the fact that her attitude is very reassuring. I mean, I think that the problem is looking at the outcomes, isn't it? Because often a lot of the outcomes in this kind of thing are fairly soft, and it's very difficult to be specific about what benefits have actually occurred. I mean, have you any approach to that?
Okay, any other, Sarah, you wanted to come in again?
Yeah, I was just going to say it's a really good point, and I think as dietitians that's something we sometimes struggle with, because it's hard to prove how our intervention has stopped something from happening, if you like. So it's hard to say, well, this group of people didn't go into hospital and that's because of something that we did. And I think gathering the qualitative measures, as well as, we're not just looking at someone's weight, did they gain weight, lose weight, that, full stop. We're looking at strength, their movement, as well as, like I said, I could talk to you all day about, pressure sores, reduced prescriptions, reduced presentation at primary care, fewer infections, they're quicker to recover. So in my head, like playing the long game, something like this where people are more empowered and we are able to support them to remain well for longer should have those outcomes. However, it's really hard to see that now, because that might not happen for 5-10 years down the line. But like my brain just can't take it sometimes.
Yeah, okay, thanks, Sarah. So Madhvi, are you happy with this, and particularly are you happy with the involvement of Chris as head of medicines management? Because anything we approve really has to improve outcomes and also be cost effective in terms of an investment. So are you and Chris happy on this? Chris isn't here.
Yeah, I'm happy with it, Nick. I've had conversations with Joe regarding this a few days ago as well. Yeah.
Okay, so last point from Joe.
Yeah, I should have mentioned, actually, I had a conversation with Madhvi last week, wasn't it? And we fed back your comments to the team, and they're really interested in exploring that idea, which was around actually could Stride work for carers of people, as well as people themselves. And we have had some correspondence with Chris as well, so I know that she'll be involved in the pilot going forward. Okay, so are there any other questions or thoughts? No. Okay, can we move to the ask of governing body, which is to agree to support the beta service evaluation and commit the resource as a partner within Barnsley, which we're now told is up to £80,000. Are we happy to do that?
Yes.
Yes.
Okay. And how will we get further assurance? How will we as a governing body or the place-based organisation get further assurance as the project unfolds, Jeremy?
So we're reporting this back through the Care Close to Home board. Yeah. And as and when we've got the sort of beta methodology and evaluation agreed between our partnership, I'll feed that back as well via our clinical lead, I think, into CCG, either SMT or governing body development session, so you can keep on top of what's going on.
Yeah, and I think I'd like to add one specific into that evaluation, and that is that we monitor the costs of prescribing nutritional supplements in Barnsley at least as closely as we have before through the medicines management team. Okay, so governing body's happy to approve that, and we'll move on. Thank you, Sarah. Thank you, Joe.
Okay,
Thanks,
so leave now. Thank you. Goodbye.
Bye bye. We'll move then on to item 14, transforming care update. Patrick is unable to be with us. Jamie.
Yes, thank you. I'll take it that governing body members have had an opportunity to read the paper. This is one of the papers that comes on a regular basis to provide an update on the work to support patients who come under the Transforming Care programme, and to discharge those patients where appropriate into placements within the local community. There's quite a bit of information in the paper in terms of background. I think a key here is that the Transforming Care programme is not new, so reference began October 2014, but on the first couple of pages of the report you can see, during that time there are still issues that arise in relation to safeguarding and other things of patients who are in secure accommodation as opposed to in community placements. So one of those were on the 9th of September, so a report published on Causton Park Hospital, which were in Norfolk, around significant failures. On the back of that, NHS England mandated that all CCGs undertake some additional checks around the safety and well-being of people with learning disabilities and people with autism who were being cared for in mental health inpatient settings. So that were in addition to the CETR, so care education treatment reviews, which happen normally. So these have had to take place in addition. We've had support from our complex case manager, Gina, who's been working through and doing that, and our LD joint commissioning lead, Alison Rumble at the council. So those reviews have been undertaken so far. 5 have been undertaken in line with the target, which was the 31st of January for those to be completed. All but 1 has now been discussed by an independent panel, so that was the next step. The one that were outstanding will be done by March 22, and the delay around that conversation was mainly related to COVID. There'll be a report, formal reports come out on the back of those reviews in due course. What is unclear at this point is whether there'll be a requirement to do those sort of deeper safe and well-being checks alongside CETRs on an ongoing basis. It were initially proposed as a one-off, so they've been done. In terms of the CETRs, that has remained a priority during COVID and over the last couple of years, and we've continued to do them as far as possible. I think one of the other things that's flagged up in the paper, when we talk about the ambition of moving people from secure facilities that may not be close to their local community and getting them into community placements, are some of the challenges around that. So flags up bottom of page 2 and into page 3, the unfortunate sort of national headlines around an individual who was detained for in excess of 30 years. Had family campaigning for the last 10 to develop local services, and that had not happened. So obviously a significant issue there, and that then got some of the national attention. So NHS England have been looking at that and the options. They've got an enhanced Tier 3 framework now to support patients, or they had a Tier 3, sorry, and that has got 15 providers on there. That's come to an end. So that's creating even more challenges for local areas to place people in their local communities. So it is an ongoing challenge and something that we need to keep focused and working on. And sitting alongside that during COVID, we know that the facilities that are available have been struggling in terms of sickness and absence and vacancies. So in terms of assurance around our local processes, so whilst it is difficult, it has been vital to retain a continued focus on quality assurance. We've continued where possible and where allowed by sort of policy around face-to-face visits and things, to do a 6-weekly commissioner oversight visit for adults and a 4-weekly visit for children. So that has continued. Where that's not been possible, the complex case manager has attended virtual meetings, liaised with advocates, liaised with family members, and made sure that the recording of all of that information is in line with requirements and is on the Assuring Transformation platform, which helps to control some of that. There's a bit in terms of the numbers, so just in terms of the number of CETRs that have taken place. So that's at the bottom of, well, middle of page 3, and then also the Commissioner oversight visits that I just referenced there. There's a dynamic support register now that were developed in 2021 and is established, and the registers are maintained by a team made up from, or teams made up from health, social care, criminal justice, housing, education. So that record means that all of the information around these individuals is in one place and available and shared across professionals who are supporting them. We've currently got 11 children, 14 adults, whose details are included on those registers. And then on the final page, there's a little bit in terms of the number of admissions. They're not necessarily admissions in this year, they're the number of people who are in inpatients. So 7 adults, adult inpatients, 3 were detained in our assessment and treatment beds, and 4 patients who are detained in locked rehab beds. And there are 4 Barnsley patients in secure hospitals at this time. So they're the patients who we are working with and supporting, and there's been 1 child admission which has occurred in the last 6 months. And then just finally, a couple of developments or updates just to provide on the work. So there have been a number of new residential homes and supported living services established in Barnsley recently. So on one hand, that's a positive, it offers alternative placements, but we've seen some challenges with that as well, because we don't have a control, and neither do the local authority, on where these facilities necessarily open up. So a number have been in the same areas of Barnsley, and we're aware that this has placed added demands then on the local GPs, who obviously provide input to those facilities. We've also have an high number of patients who are placed from out of authority, and whilst there's an host commissioner responsibility for those, there is a financial risk to us should the patient require detention under the Mental Health Act, because at that point the CCG and local authority would become responsible for their care under the current Section 17 117 funding arrangements. So that's there. I think we've previously reported around a facility that we commissioned as part of the Transforming Care partnership with Calderdale, Kirklees and Wakefield, a new facility, 2.8 million housing development at Mayman Lane, which is at Batley. That opened on the 8th and has now got 4 residents in there and has got 2 vacancies at the moment. So patients are being placed in there. South Yorkshire Housing Needs Assessment has been delayed slightly. That was supposed to be done by March 21. That is due any time now, and that's been done across South Yorkshire, so that should come forward. There's work that providers are taking forward around safe space, and this is different to some work that we've been doing around mental health safe space. This is creating spaces that providers can offer and utilise as step up, step down to avoid a permanent admission. So it might include facilities, accommodation with support. And then just a final point, which is around the Transforming Care partnership. So whilst we've still got a link and formally remain part of the West Yorkshire Transforming Care partnership at this point, as we move into the ICB, we are in a transition period and will move across into the South Yorkshire Transforming Care partnership. So we've started that, and all our reporting and financial information goes that way now. We're currently attending both sort of partnership meetings, but during this next year, we'll transfer formally over and become part of the South Yorkshire partnership aligned to the ICB. So that's a quick run through there to try and provide an update on where we're at with the Transforming Care programme. Thank you.
Thank you, Jamie. I don't think you've missed anything. Does anyone have any questions for Jamie? No. So we're asked to note the contents of the report. Mike?
Yeah, I mean, when we were with the kind of Yorkshire group, the West Yorkshire group, we supported the development of the Mayman Lane complex, which seemed a very positive development. Will we still have access to that when we're with the South Yorkshire ICB, or will that be become unavailable, because it seemed to be a very positive development?
Yes, we will continue to have access. We've been really clear throughout the process of the transition that any of the arrangements around provider, so still working with Swift across that footprint, and the contracts that we've got and the arrangements that we've put in place, they will all continue to be available to us. Yeah.
Thank you. Any other questions or? No? Okay, thanks, Jamie. Thank you for that. And thank you for stepping in at short notice. Wow. Can we move on to item 15, Cancer Assurance Report, Hussain and Siobhan, please.
Good morning, Governing Body. So this is a report that's a follow-up to the paper that we had at the last Governing Body, and there was a number of areas that we were asked to report back on. So that's what this report is about. And the first area was about asking about the clinical prioritisation process, and whether as part of that clinical prioritisation for people who are waiting for treatment and for diagnostics, whether their cancer prognosis was taken into account. I can confirm, having spoke to the hospital once again, that that is included in the prioritising process. So I hope that reassures the governing body that prognosis is definitely included as a criteria within the clinical randomisation prioritisation process. Okay.
Okay.
The second question was about the breast screening, and it was posed at the last meeting to explore if breast screening, the additional machine that's been commissioned and funded by Public Health England, could be mobile. Unfortunately, that is not a possibility at this stage, because although it is classed as a mobile unit, it's actually a static unit, which makes it different, doesn't it? So the way that I described it, it's not mobile, moving around easy. It's like a static caravan, and if anybody's got a static caravan, you know that it's quite hard to move it. So it's quite static. So we wouldn't be able to do that at the moment, and it wouldn't be so simple to just move it to a variety of places, because for number one, we'd have to also have the IT infrastructure in place to be able to make sure that the screening service can actually be delivered, and that would be quite difficult. So we couldn't do that at this time. So having spoke to our Public Health England commissioning colleagues, what they've asked me to sort of put forward is that to just give a summary about what we are doing to make sure that we target patients to come forward for breast screening who don't traditionally come forward. So the focus is therefore on targeting people who do not attend, who want to attend, and we're using the nudge method, which is an evidence-based intervention to try and encourage people to change their behaviour and want to come forward. This includes via text messages that remind people that screening picks up more people with breast cancer than they do if you present to a GP and at a much earlier stage, and the prognosis is much better if you come for screening. Most people will not have cancer symptoms or not have cancer after screening, so we're trying to say, don't be not afraid to come forward, that actually this is a simple test, but it's really important, it'll reassure you, but remember the majority of people who do have this will not come forward, because we do know that patients get worried that they don't really want to know sometimes that if they've got cancer. It's just part of that normal human nature. We're also saying that they only need to come 3 yearly and focusing on that, and it's a very quick test, you know, that it's come forward and it's only once, so we're trying to make access as easy as possible. The other thing we're trying to do is really focus on making the case for really easy access, and the way we've done that is we've developed breast screening now will be moving from early April to the Glassworks town centre location, and as part of that development we also have an additional machine that will be located there. So we've got one machine at the moment that is permanent and one that is temporary, but at the Glassworks we will definitely have 2 that will be running all the time. And the reason that we're focusing on getting everybody to come to the Glassworks for the breast screening is, number one, it's easy to access, transport links are brilliant, parking's brilliant, and its main focus is really to try and get people to come there. And also the Glassworks is not going to be very medicalised. It's going to be a place that doesn't look like medical. It's going to be have soft light. It'll have an infrastructure environment that makes you want to come there and feel like you're not coming to a medical appointment, really. So the main focus of the Glassworks will be to target people who have not come forward to this provision. So we'll target them. It's going to be a place that hopefully people feel less anxious, anxiety, and feel that they want to come to. So we'll have volunteers there who will be able to help people who are anxious to come about appointments. We're also targeting people with learning disabilities who do not come forward for appointments already, and that is having a good uptake of people coming forward now. We're working at practice level to target people who are not attending, especially using the additional roles that the primary care network have got are supporting. So the care coordinators are targeting people who are not coming forward, and we're using the Nudge Behavioural Insights work within practices to target those groups and use evidence-based interventions to get them to come forward. And Dr. Gadash is now going to explain a little bit about his experiences to just give a bit more in depth about why we feel this will actually lead to a really good outcome for patients, and we'll be able to increase the targeting and the uptake of people who don't come forward at the moment.
Yeah, thank you, Siobhan. Good morning, everyone. Yeah, just going back to what Siobhan was saying about inviting patients to come in for screening, it's always been a challenge, as we know, in the primary care, and using the nudge works and the inside behaviour, I think that'll be a good thing, because, for example, I mean, just going from my practice point of view, we have two sites, Goldthorpe and Thurnscoe, two sites, and sometimes we have patients booked in to have the screening done in cervical screening done in Thurnscoe. Unfortunately, the nurse is not there or something happens, so we often give them the same day appointment to come to Goldthorpe, but they're reluctant to do so because they want the familiarity of of going into the practice they're used to, seeing the nurse that they feel comfortable with. So having the Glassworks with with a lot of support and for the patients, I think it'll be a good thing, for the breast screening and so on. I hope it's a good thing. So see how it goes.
So therefore, to just summarise, we can't have a mobile going around at the moment, but what we're saying is we really need to focus and get people come to the Glassworks, make Glassworks a place people want to come. So we've just done some patient engagement around what people want in the Glassworks, and it will, they do want, we've taken that on board, so they don't want it to look medicalised. They want to make sure when they come for the screening that they've got something to focus on if it's uncomfortable, to put the mind off. But we'll have volunteers there, and we will target people who we know traditionally don't come.
Okay, thank you. Are there any questions or points people might wish to add? Okay, I've got one. And it seems to have been a missed opportunity, but there are a number of lifts that do have the technology for MRI scans and other things to plug into that have never been utilised. So it begs two questions. One, why was this facility commissioned? And two, why we're not trying to maximise opportunity there. And I'm sure everything that you've said does provide assurance and is better for patients. But it could also be better because whichever way you do it, some people find travelling a long way, and however acceptable it is, they know what they're going for. So the more barriers we can manage away for them, the better. So I think it's an ongoing journey, but it seems like you provided the assurance that we asked for, which is very welcome, I think, for the people of Barnsley. Thank you.
Very much.
Okay, if there's no further points, we'll move on to item 16, Primary Care Medicines Optimisation Protect Programme. Madhvi.
Hi there. I'm just wondering, I am here, so I was just wondering if I could pick up for Madhvi.
Yeah, you can. I didn't see you were there, by all means.
Thank you. So what I wanted to do was update the committee today about what is quite an exciting piece of work. It's quite an exciting opportunity. The PCCC have endorsed the funding for which is pump and prime funding for this piece of work to be undertaken this year. And if I could I'll take the paper as read, but if I could just give sort of a brief description of the work and the approach to it. So As you know, the medicines management team, we actually work closely with practices, identifying cohorts of patients and targeting, reviewing patients and supporting patients, and adjusting medication and intervening, undertaking interventions to sort of improve outcomes for patients. But this piece of work is a radical change to how the medicines optimization team currently work. So it's piloting, identifying cohorts of patients and working with a software provider that currently we use for the radar function, the Eclipse Live software, and working in partnership with them, but closely with the practices, about, for those identified cohorts, to engage directly with the patients through an online platform. The majority of the work would be undertaken by the Eclipse team, but there would be escalations and potential calls to action that come out of this work for a few patients, and we would route those in terms of management with agreement with the practice. So I did put a couple of examples in the paper, and I will go through those. But the amount of work would be undertaken by the Eclipse Live team. The work is, in terms of engaging the practices, so there's the approach to this approach has actually won several awards, and is really about onboarding patients to actually engage in their self-management. And what is striking from the papers, the reports of that work, is actually how much patients like this approach and how much they actually do change their attitude just by being involved. So if I could, the example that I gave in the paper was around patients potentially who may be hypoglycemic. I'll have a risk due to their medication, that they could potentially, at any point, if they stopped eating or if they lost weight, they could actually, their blood sugar could lower. So identifying that cohort, contacting with them and reminding them around the monitoring of the blood sugar and around the dietary, the lifestyle, could actually identify if any patients did drop out of that cohort. But just the process of contacting them would actually probably make them more, well, in line with the papers, would make them more compliant, would make them better engaged in the care of their condition. In terms of the process for the work, we've drafted what is a high-level project plan. It would be engaging around one or two areas, just one or two areas with all of the practices. Started the process of seeking GPs, clinicians that want to be engaged, as well as practice managers, and there are a few people who are already interested. And I think it's just developing, learning and developing, working with them, and then rolling out. This actually has an enormous potential around targeting whatever cohorts we wish to. So it could be amplified and driven. We've built in what is an evaluation on the work that's gone on, to actually inform for potential future funding into past this year, past this next year. And I think it's quite exciting, and I'm going to open it up for questions there.
What's the priority area of work for this project in terms of the approach? Because it would be good to look at where the biggest morbidities are, and what do you think is the priority, Chris?
Yeah. So you saw within the paper there was the table about those 6 therapeutic areas, right. And the 2 largest ones, we had what I thought was the largest one, which was around hypertension. Right. And the potential with hypertension, because that, in terms of joint focus, captures so many different areas, doesn't it? It captures, you know, we've got all of the NHSE expectations around delivery on service models. We've also got, we know about the potential impact when I look at the variation of what we've got in terms of admissions and lengths of admission, and also the monitoring that we've got, and we know that we need to case find as well. So that was the first one. However, we have just had the advice from NHSE around the DOACs. That came in, it was sort of back end of last year, and we took it to Area Prescribing Committee. So this is about the move of the first line DOAC to a doxaban, and there being significant financial advantages for the health community, as well as clinical benefits around from what we're currently doing. So that potentially is the next largest one, Nick.
Okay, any questions for Chris? No, okay, so the governing body ask, let me just find that, is that we note the planned implementation of the programme and continue to support it.
Yeah.
Was there any other ask?
Not at this moment, no.
Because you mentioned something about future financial
engagement.
Yeah, you did mention something about future financial implications. Did I mishear that?
Yeah, no, that was in terms of, so the funding is for this year, it's non-recurrent, but we have built in an evaluation, so there will be a need to, as place, and I know at the moment I'm aware of the changes that are going on, but to take that evaluation and to look at it in terms of consideration of future financial investment.
That's a future decision, isn't it? So the business today is to continue to support and to look forward to the evaluation. Yeah. Are we happy to do that as a governing body? Yeah. Okay. Thank you, Chris.
Thanks, everybody. Thank you.
Thank you. Can we move then on to, thank you, Chris. Can we move on to item 17? Send written statement of action, Jamie.
Yep, thank you. So governing body members will recall that at the last meeting I brought a paper which set out the outcomes from the joint SEND inspection which took place at the back end of 2021, and recall that the letter that came out on the back of that inspection identified 2 significant areas of concern that the inspectors had found. They were around, one was the engagement and communication with parents and carers. Local statutory partners need to ensure that the lived experience of families is influencing their strategic plans and services for provision. So that was the first. And the second was around improving the identification of and provision for children and young people with SEND, but without an education, health and care plan. So people who are sort of at a lower level, not been through that formal process. So following receipt of that letter, there were a number of things that we had to do. So in essence, against those 2 areas, we had to submit a written statement of action to Ofsted and the CQC within 70 days. So that was the 28th of February. So that has gone in draft. We will receive feedback. Well, we should have received feedback actually by it's 10 working days. So we'll be receiving feedback anytime now on that from Ofsted and CQC. Once that is deemed to be fit for purpose and they accept our plan around that, there'll be a requirement for us to publish that on our websites, and the Department for Education, along with NHS England, will provide support and challenge to statutory partners around, one, the written statement of action and the improvements there, but also our wider improvement plan for SEND, because there are other areas that we want to take forward that are not included in there. The way that we'll locally oversee the SEND improvement plan, once that is signed off, will be through the SEND oversight board, which I attend, but is also representative of all partners who support SEND children. It'll also be reported to Cabinet on a regular basis. I will make sure that there's updates into SMT and into the paper says CCG governing body, but whatever forum that may be throughout the year. And then just a point to note, what would usually happen under the framework, SEND framework, is that there would be a follow-up inspection. But there's a change in the framework that is impending. So any inspection that took place after June the 21st, there will not be a follow-up visit under the current framework. So any subsequent inspection will take place under whatever the new framework is that is developed. But as part of that, they will look back to make sure that we've made the progress against the areas that were identified in the report. So that's the update, and attached to the appendices, and I'm not intending to go through that. Hopefully people have had a chance to have a look through, but is the plan against the two key areas that are subject to the written statement of action. That's
happy to take any questions. Do we have any questions? People have looked through the plan. The ask of us is to endorse the Joint Council and Barnsley written statement of action and to endorse the improvement actions to be undertaken. Are we happy to do that as governing body? Yeah, that's good. Thank you. Thanks, Jamie. Can we then move on to item 18, quality highlights report? Madhvi.
Yeah, thanks, Chair. So I'm just sort of bringing quality highlights report to the governing body today. I take it the paper has been read, but I just want to bring your attention to some of the areas. So the first one I want to draw your attention to is the Barnsley Hospital Urology Service update. So following a series of incidents which happened at Urology Department, mainly relating to the systems and processes in place for follow-up of urology patients, there has been an extraordinary meeting held on 27th of January 2022, and Quality and Patient Safety Committee has been updated on the discussions which happened at BHNFT Clinical Quality Board in terms of the serious incidents and what actions and the progress in terms of actions that have been agreed. Although the committee felt assured that there has been enough sort of progress made in terms of actions, etc., we felt that it was very important that this is closely monitored. So it has been agreed that this will be monitored at each clinical quality board at the Quality and Patient Safety Committee meetings. In addition to that, there has also been a sort of serious incident relating to a colorectal cancer surveillance that happened, again relating to the follow-up of the patients. Again, there has been actions drawn up, and we agreed that this will be brought to QPSC, that is Quality and Patient Safety Committee, through the Barnsley Cancer Steering Group, and this will be monitored on a regular basis. The second item is intermediate care. The chief nurse provided a briefing on to the committee about the latest developments for procuring medical oversight for ACON unit from 1st of April 2022. So it has been agreed that provided the procurement process goes smoothly and the service will be starting as expected without any glitches from 1st of April, that the risk rating on the risk register in relation to this topic would be reduced or potentially removed. So that's sort of significant progress provided the procurement happens without any problems. The next item is around the discharge summaries. As we know, there has been issues and there are ongoing issues which are continually being monitored. There has been an additional issue lately with a new format which has been agreed through by BHNFT for discharge summaries which come back into primary care. And it has been identified that there were lots of issues, especially around Some of the discharge summaries were illegible, or there had been multiple discharge summaries coming back to primary care, or they are actually coming in before the discharge of the patient, or there has been instances where it's come to primary care's attention even before the patient has been discharged. So we have been assured that the medicines management team is actually undertaking active monitoring on this piece of work, and any issues are being regularly fed back to the EPS implementation team. So that is work in progress, and any issues are being addressed as we go along. The next item is about Yorkshire Ambulance Service and serious incidents. Quality and Patient Safety Committee received an update on the management of serious incidents reported by Yorkshire Ambulance Service since 1st of April. This issue has been escalated to the Yorkshire Quality Surveillance Group on 27th of January 2022 because it looks like Yorkshire Ambulance Service is still classified as being under routine surveillance, and it was evident from the meeting that the increase in serious incidents that have occurred in Barnsley are not reflected in the other areas of South Yorkshire. So the Chief Nurse has agreed to raise the issue with Yorkshire Ambulance Service Commissioner Wakefield CCG with a recommendation to put Yorkshire Ambulance Service under enhanced surveillance. The next item is oncology provision. The committee has received a detailed update on the latest position regarding oncology provision for Barnsley patients. It is to be noted that we've been informed that the capacity of oncology consultants across South Yorkshire has declined further. So the committee received details of measures that are being taken to manage the current position, and we've been assured that stakeholders were working on long-term solutions. We did feel at the committee that the latest position in relation to sort of reduction in the number of consultants providing the service, that we should increase the score of oncology provision risk on the risk register to 20. Yeah, and the last item I've got is about adult salt service provision. The committee was updated regarding recent concerns from the external stakeholders regarding the level of adult salt service provision in Barnsley. It transpires that there are like really long waiting times for salt team assessment for the patients who need it. Based on the information, and also it's to be noted that there has been a delay in the expected review for the service. So based on the information received at the meeting, the committee agreed that the adult salt service provision in Barnsley should be placed on CCG's risk register. I'd like to invite Siobhan at this juncture just to give us a little bit more update about the salt provision service, because it looks like there has been significantly increased delays in patients being assessed who have been referred to the service. Siobhan, do you mind updating governing body a little bit more on this topic, please?
Yes, Dr. Kutamukla. So the issue around here was actually about the speech element of the speech and language therapy service. And what it was is that we've had brought to our attention as a CCG by a consultant, and also the MND, which is the Motor Neurone Disease Society. There's a lack of provision for people with neurological conditions around speech and support. So on initial investigation, it looks like that is not being provided at the moment, or there's a big waiting list for it. And I just wanted to assure the governing body that actually we now have a commissioning manager who is looking into where is the gap, where is the risk to the CCG, and is doing some scoping work over the next month to look at what's the demand capacity, how do we make sure that those patients who need it straight away and are not getting that service are prioritised to get it. And also what will happen is any proposal and any solutions to be able to provide the speech element of the speech and language therapy by SWIFT to neurological patients will come to the clinical forum to discuss and to gain their advice about a proposal about how we address this gap. And then we're intending to bring to the next governing body a proposal about how we address the gap and mitigate the risk. So it was raised at quality in the quality patient safety committee meeting, but Commissioner already put some resources and will put some time in to address this issue as soon as possible.
Okay, thank you, Siobhan. Thanks, Madhvi.
Thanks, Steve.
Are there any questions for Madhvi or even Siobhan around the quality highlights report? Chris Millington. Chris.
Madhvi, can I take you back to, dare I say, D1s? I understand there was a meeting yesterday, yet again. I don't know whether you were part of that meeting.
No, Chris, I wasn't part of that.
Okay. My question really was, have we now got potentially a hope for gain that this will finally get sorted? Can you give any assurance on that?
Yeah, I think, like I said, the medicines management team are very actively monitoring this. I think we have seen a little bit of a difference in the practice in the sense that where it was illegible, that seems to have been sorted. The only issue I've seen at the moment is multiple discharge summaries for one patient. But I suppose I think the immediate safety issues have been addressed, especially with the illegibility. But I guess I think hopefully not long before it gets resolved. Chris, yeah.
Thank you.
Thanks.
Anybody else? Any questions or thoughts? No? Okay, thanks, Matt. Thanks, Chris, for that question. Can we move then on to item 19, Richard, please, Risk and Governance Exception Report.
Yep, thank you, Nick. So I'll take the paper as read and just confine my comments to picking out a few of the key points. So the paper today covers a number of different things, starting with the assurance framework. So as always, the governing body has in your pack the latest version of the assurance framework, which has continued to be reviewed and updated. There's no sort of particularly notable updates or changes to that, so that's really there for your information and assurance. We then have the corporate risk register. Again, this time you've got the full risk register, including all the risks, red, ambers, yellows and greens. That's because we bring it in full a couple of times each year, just so that governing body can be assured that all of those risks are subject to continual sort of update and review. The covering paper lists out the ones that are currently rated as red. And then the thing that I would particularly bring to governing body's attention is the fact that we have two risks, one of which is 13/3 relating to sort of A&E, waiting times for treatment in A&E, and one which is 15/12 relating to 62-day waits following cancer referrals. Those were considered at Finance and Performance Committee last time, and that committee is recommending that the risk ratings related to both of those risks are increased up to 15, which would put them in the red risk category, and that's reflecting current challenges in those services related to things like obviously the pressures resulting from the COVID pandemic. So we're asking governing body to approve the change in scores for those two risks. Then my report also includes the CCG's workforce report for Q3 this year. So the management team gets these obviously every quarter, and we bring them into governing body just for governing body's information on a sort of once or twice a year. So thought it might be interesting to bring this one in. The report provides, assurance to us. I think that broadly speaking, we have pretty low levels of staff turnover, pretty low levels of staff sickness absence, although you may have spotted that along with the rest of the country, there was a slight uptick in sickness absence in the sort of late November and December period as the Omicron wave took hold. But the overall rate continues to be pretty low, and our stat and MANT training compliance levels are high, and obviously that's something that we can be very pleased about as a CCG, I think. Then we have committee terms of reference. So every committee reviews its terms of reference at least annually. At the last meeting of the Equality and Engagement Committee, which took place in February, that committee looked at its terms of reference and were happy with them as they stood, with one minor change recommended, which is that the deputy chief nurse, which is who was previously included amongst the membership of that committee, it's now recommended that we take that post out of the membership of the committee, as the individual who held that role has now left the CCG and moved over to Barnsley Hospice. And then also for governing body to note, Remuneration Committee has recently done its annual review of its terms of reference as well, and is not recommending any changes to those at this stage. And then the final thing in my pack is the governing body sort of work plan, which now extends only as far as May, because if the timetables for transition continue as we expect, that will be the last sort of full public meeting of the governing body. So the work plan is just there really to assure the governing body that we continue to plan ahead, and that we're trying to anticipate and make sure that we bringing through governing body the business that we need to do. But if there's anything there that people think I've missed off that needs to go on there or whatever, you can either tell me now or bring it to my OK's attention outside the meeting, and we can get that sorted. So that was all I was going to say, Nick. I'm happy to take any comments or questions.
Any questions for Richard or comments? I have one thought, Richard, and that is that by May we'll have a better understanding of place structure.
Yep.
And I think if it's possible for May governing body, and I think perhaps Chris Edwards might, as AO, might agree, that we have an understanding at that governing body in terms of due diligence of where some of the main strands of work that we're currently doing, where they will sit.
Mm-hmm.
If that's going to be possible by May, just to make sure that we're not dropping anything in the transition. I'm pretty confident we won't be, but I think it will be good for governing body to see that and to be assured on that.
Yeah.
And we won't have been able to do that yet, but as the place arrangements become more defined, and with the place-based leader and various other things, we'll be able to see which bits will fit where and with which part of the new structure. And I think for us that will be an assurance. Chris?
Yeah, we can certainly do that, Richard. We can certainly do an update, even if we've not got the final version, can't we? So we'll be able to give the governing body an update and assurance of where we're at.
Yep, that's fine.
Great. Yeah. Okay, Richard, do you want page 166 just formally take us through the governing body ask, please?
Yep, thank you. So it's just to review the GBAF, which I think we've done, and consider whether the risks are appropriately described and scored. So I'll take it as sort of that the governing body is okay with that. Identify any additional positive assurances for inclusion on the GBAF. Well, I've not heard of any of those, but obviously if anybody comes up with anything, do let me know. Review the risk register and confirm that risks are appropriately described and scored. Yes, we've done that. Note the Q3 workforce report. Yes, we've done that. I'm asking governing body to approve the change to the terms of reference for the Equality and Engagement Committee. So I will take it as approved, if that's okay. Consider and approve the work plan. Well, yes, we'll take that as approved, subject to the comment that Nick has just made about the extra assurance to bring in May. And then we are noting the increased scores for 13.3 and 15.12. So yeah, I think we've covered that ask off. Thank you, Nick.
Okay, so governing body's happy with all those bits. Thanks, Richard. So thank you for that. We'll move on to item 20, the integrated performance report. Roxana, do you want to take us through the financial bit, please?
Yeah,
and then Jamie through the performance. Thank you.
Thanks, Chair. So the paper here today just sets out the financial position of the CCG. It's in line with the previously reported position to the governing body. So the current position is that the CCG will deliver a £2 million surplus during the financial year 21-22, which ends on the 31st of March. There are some still further outstanding allocations to receive to enable us to achieve that position, which total £3.95 million. These relate to the hospital discharge programme, the additional roles within primary care, and primary care winter access funding, so that we have actually received some of those allocations since this paper was written. So, and then there'll be adjustments in month 12. As we kind of approach the year end, prescribing's probably continues to be one of our most volatile areas of expenditure. So we are working really closely with our head of medicines management, Chris Lawson, just to ensure that we can get a clear position on that as we approach the year end. The reason for some of that is that obviously some of the staff were deployed during the Omicron variant to deliver vaccines, which has impacted on the delivery of efficiency programmes within the medicines management team, which is now impacting on prescribing numbers as they're coming through. So we are working really closely with Chris just to make sure that we have captured the correct position as we get to the year end. I'm not anticipating any further risks. I think as we get to the year end, we should deliver where we've been reporting for the last few months. There shouldn't be any further material things emerging at this point, particularly as we're on the 10th of March already and we close down in 21 days. So that's my finance update today. So fairly brief, but I think covers the key points. But I'll take any questions.
Doesn't look like we have any questions for you. Are there any questions? No? Okay, Roxana, thank you for that. And then we'll move on to the performance part of the report. Jamie, please. You've been busy today, Jamie.
Always busy.
We'll get there.
It's good to be. No problem. So as usual, the information that's presented to governing body has been presented to and reviewed by the Finance and Performance Committee. So what you've got is a summary of the headline performance against some of the key constitutional measures, highlighting some of the areas where we've got challenges or we've seen reduced performance. There's a couple of areas in here that obviously relate back to the paper that Richard has just presented on risk, which is why the risk ratings have been increased. So I'll just take you through the key elements. In terms of urgent care, A&E performance, activity numbers continues to be presenting a significant challenge. We have seen a slight reduction in the numbers coming through, but continue to see sort of peaks and troughs with certain days, really high numbers, or certain times of the day, really high numbers coming through. And that is having an impact in terms of the ability to see patients and either discharge or admit within 4 hours. So that continues, and you can see we were around 77% for Barnsley patients, and Barnsley Hospital, which obviously as the main provider, similar position. I want to make the governing body aware and raise awareness of a number of 12-hour trolley waits. So one of the measures that has been included in the Constitution and the NHS sort of requirements is that there should be no patient who waits longer than 12 hours following a decision to admit to be admitted. Barnsley Hospital have always been really good performing in this respect and have not seen 12-hour trolley waits. We've had the odd one through COVID, but in January, because of the significant pressures, because the hospital were at capacity in terms of beds, the community were struggling because of a high number of care homes that were closed because of COVID, and there was sickness around. That created a challenge with flow, and we actually saw 9 12-hour trolley breaches in January. I think the important point to bring out is that all patients, where appropriate and where they could be spoke to, were spoken to by a director who were leading the response at the trust, and whilst it doesn't solve the pain, but an apology offered regarding the long wait and an explanation provided. There were no complaints received by the trust, and whilst patients were waiting, they weren't on trolleys, they were put on beds ready to go to the wards, in the emergency department, but they were provided with food. There were regular safety checks and monitoring, as there would be if they were in the ward, and the trust has submitted reports as appropriate, reviewed all of the usual patient safety channels, and concluded that whilst it's unfortunate that some patients waited longer, there were no patient harm resulting from that. So I think that's an important point to take. We still continue to see challenges in terms of ambulance demand, so response time down, but our handover performance in Barnsley is reasonably good and continues to compare well to our neighbours and national figures. So that's urgent care. In terms of planned care, the sort of 18-week RTT performance, it did slightly deteriorate from December to January, but a fraction of a percent, and we did see, as I've suggested, a massive increase in pressure across the trust in January. So maybe a reduction in some of the electives, which has slowed down the progress in reducing the long waits. Overall, the trajectory is still good, and we've still got plans in place to reduce any long waiters. And as you can see in the paper, the number of 52-week waits continues to reduce, so another 19 patients less. The majority of the long waits are trauma and orthopaedics, and as part of the planning process that is going on, and we picked this up at Finance and Performance Committee, discussions are taking place around how we can collectively across the system, providers can work together to try to address some of the areas where specific specialties are facing longer waits than others. So that's where we are with that. In terms of those 52 weeks that I talked about, well, I've said majority at trauma and orthopaedics. Sorry, I'm 104 weeks, which is the next big challenge. So there's an ask within the planning guidance for next year to reduce this to 0. We've got 8 patients currently. Barnsley Hospital have got no patients currently at 104 weeks, so they've got no patients who have been waiting over that time, and we've not seen any change in that position since this reported number. So our plans for next year will be to maintain that and to reduce down and make sure that we've got minimal numbers of 52, aiming to get back by the end of next year to no 52-week waits at all. And then in terms of diagnostics, that were an improvement slightly in performance. We've still got 20% of people who are waiting longer than 6 weeks for diagnostic treatment, and the underperformance continues to be driven by long waits for non-obstetric ultrasound, nearly couldn't get that out then, and CT. So that's where we're at in terms of elective. In terms of mental health, we're still facing challenges around IAPT access. We know that the prevalence there is increased, the expectation in terms of access rate is increased, and I know we've got a paper coming up in private later that talks about this a little bit further and plans to try and address that change. The other IAPT measures we do continue to meet, and we continue to see people move into recovery. And then there is cancer data included. Unfortunately, there were delays in the availability of the data, so all that was included in the dashboard is up to December 21. So it does show that still across most of the cancer measures we are not achieving the standard. We picked up at Finance and Performance Committee a conversation around 2-week wait breast, which has deteriorated quite significantly. We've had previous conversations around that in terms of capacity at the trust. I followed up some conversations, and they have got some staffing issues that are having an impact there, but we've agreed to pick up a further conversation on that and make sure that when we bring back any next cancer reporting, we're able to give an update. What I would say when you look at the dashboard that's on the back is that we did have reasonably good performance. It dipped as a result of some of that staff in absence, but it is climbing back up towards a better position. So it's not there yet, and we'll bring some assurance around the work on that in a cancer update report in future. So that's it for me in terms of the performance areas. I'll take any questions on that.
Any questions for Jamie? No. Okay, thanks, Jamie. So that moves us on to a series of committee reports and minutes. Sorry, to go back on the IPR. The governing body has noted the contents of the report, including performance, which Jamie has taken us through, and the projected delivery of a 2 million surplus and achievement of financial duties predicated on the assumptions in the paper and mitigating actions from Roxana. So that's the ask of the governing body. So thank you for that, Roxana and Jamie. We can now move on to series of committee reports and minutes. The first one is the minutes of the Membership Council, the 19th of January. Happy to take any questions on that if there are any. No? Okay, can we move on to the next 21-2, unadopted minutes for the Audit Committee of the 13th of January. Nigel, is there anything there you want to pull out or say anything about?
I don't think so. The main item was extending the external audit contract. That's already been reflected to the governing body. Okay, thank you. And then we've got two sets of adopted finance and performance minutes, 6th of January and 3rd of February, and they're there for assurance. They've both been adopted. Happy to take any questions on those. No? Okay. So 21-4, assurance report of the Primary Care Commissioning Committee and the minutes which have been adopted on the 25th of November. Chris, do you have anything to wish to pull out, anything of these?
As you say, Chair, there is two papers there. There's November and January. With governing body's permission, I'd just like to cover January 22, if I may, which is all about the Winter Access Fund. So just give you a thumbnail sketch that Primary Care agreed to make available a sum of £3 per head of the GP registered population as of October 2021 for practices to use over the remainder of this financial year to fund activity linked to the areas of the Winter Access Plan. This was intended to cover all of the associated costs. We also agreed £1 per head of population to be used to fund additional activity over the remainder of the year in iHeart, extended access, out of hours, home visiting and COVID clinics. In total, this investment equates to £1.2 million across Barnsley, which is available to support access to and the resilience of general practice. It was further agreed that we would have a robust audit trail in place to monitor outcomes and value for money. And that's all I have to say, Chair, on the January paper.
Thank you, Chris. Okay, we're all happy with that. So we move on to 21-5, which is minutes of quality and patient safety on the 16th of December. I think most of those issues have been picked up in the highlights report today. So if there are no questions on that, could we move on then on to 21-6, report of the Equality Committee on the 24th of Feb and the minutes of the 18th of November. Reading through those, Chris, I didn't see anything highlighted. Is there anything you would like to share with us? Can't hear you, Chris. Can't hear you.
£5 fine, yeah. So on the two papers, no, there's nothing to highlight, Chair. The papers are here for assurance.
Okay, so that's Equality and Engagement Committee, and then we move on to 21-7, the unadopted minutes of the Health and Wellbeing Board. And on page 353, you'll note my resignation from being the co-chair for reasons which I've shared with the Health and Wellbeing Board. If there are any questions on that, I actually wasn't at that, but I'm sure we've got somebody who could take questions. Is there anything on that? No?
Myself and Jeremy were present. Nothing to highlight, Jeremy, I don't think, is there?
No,
there isn't.
Okay, so thank you for that. Then we move on to reports circulated in advance, which you've had the opportunity to read. And we come on to the final bit, which is reflection on how well the meeting's business has been conducted, and if anybody feels there are areas for additional assurance that we need, or if anybody's identified any training needs, or are we happy with the meeting? Is there anything? Okay, that's really good. So at this point, we conclude governing body meeting in public. It's the point at which we, as described, exclude members of the public and move to the private section and close the meeting. So thank you, members of the Barnsley public. Thank you, governing body. Thank you, Kay. And thank you, Kirsty, for recording. The time is 11:40. Do we want to reconvene at 12? Is that okay?